comes up not infrequently in our Center of Excellence discussions with patients. And what has happened, especially during the pandemic, is that our patients who may be late stage are not necessarily making it in for visits. So we've been doing telemedicine with some of these patients, and it really brought home the fact that some of these topics we need to make sure we keep coming back to and readdressing and answering questions for families as well. So we're going to walk through middle and late stage Huntington's, and let's see here. This is what we're going to talk about today. For the middle stages, I'll talk a little bit about signs and symptoms that may be problematic for patients and families, and discuss some adaptive devices and other strategies you can use to address those. And then I'll walk into later stages of Huntington's disease and also discuss palliative care and hospice as well. So I just wanted to remind the group, many of you may know that there are symptoms in Huntington's disease that fall into three main buckets: the movement disorder, the cognitive disorder, and the psychiatric disorder. So the movement disorder is characterized by these extra movements called chorea. They're kind of random movements that can occur anywhere in the body. They're unpredictable. Balance difficulties can start even quite early in the disease, and most Huntington's patients, as the balance problem worsens, will also start to fall. And so this is an issue because it causes a whole host of secondary problems that we're trying to treat in the clinic. Now, the next bucket of symptoms that we are coping with are cognitive disorders. Memory decline is common in the disease. It can be the first symptom, although frequently it will occur after the movement disorder, the chorea starts. There are also some changes that we see in personality, and there's some issues as far as the patient understanding what's happening to them, what we call insight. And this is really something that's characteristic in Huntington's disease. We don't see it in a lot of other brain diseases. And the way it manifests is that a patient will come into the clinic with their family member. I'll ask a question such as, how's your balance? The patient will say, it's just fine. And the family member will say, well, he fell 3 times yesterday and has been having a lot of problems. So there's this disconnect between what the patient says and what the caregiver or family member says. So this insight issue, it can be a major problem, and it continues throughout the disease. So it may start early or later in the disease, but it really impacts our ability to treat symptoms. And that's why we really love it when we have family members or caregivers that can come into the clinic with the patients. Now, the last bucket of symptoms are psychiatric symptoms. And these, I believe, are probably the biggest problem our patients face with Huntington's disease. And that's partly because they can be challenging to treat. Now, irritability seems to start earlier in the disease than some of the other symptoms in this box here. And irritability can be variable. It may be situation dependent, or it could just be irritability in general. Sometimes it's directed more towards a caregiver or spouse than it is others. Sometimes it's everyone. So it kind of depends. We take the history in the clinic and then try to deal with it as it's reported. Anxiety and mood disorders are also common. Anxiety can manifest in specific areas. So for example, someone may be very anxious about urinating. And it may be that we hear this anxiety around urination over and over again, when in fact other issues are not nearly as anxiety provoking. So it can be across the board, or again, it could be situation dependent. Many patients with Huntington's, especially early in the disease, after they start having symptoms, will report that their mood is not as good as it used to be. And in fact, some patients, the mood is kind of to the stage where it cause folks to have some suicidality. And I'm going to come back to that a little later in this talk. Now, a smaller proportion of patients will develop delusions, hallucinations. And the delusions are kind of fixed thoughts that aren't true. And one of the more common delusions we see are delusions of fidelity or delusions of paranoia, where Huntington's patients are kind of, suspicious of others. They're concerned that, people are out to get them or out to hurt them. This can be a problem for caregivers. It also can be a problem if they get admitted to the hospital, because they can be suspicious of the healthcare providers. Hallucinations can occur, they're visual or auditory hallucinations, and frequently the patient does not recognize that they're not real. So in fact, they can be very bothersome to the patient. So let's talk for just a minute about the time course in Huntington's disease. And what you can see in this particular slide is a kind of a time course, although this doesn't really translate to every patient. It gives you some idea of the milestones that happen. So many of our patients will develop the disease when they are an adult. And so let's just say the patient has predictive testing around 25 and finds out whether they're gene positive or negative. And in this situation, they're gene positive. It's actually going to be several years, even 10 or 15 years before the symptoms manifest and before we see any chorea or mood or psychiatric disorders. And so there's this window where patients may not actually be coming into the clinic for care. They have a positive test, but they really don't show up until they need treatment or want to talk through some symptoms. Once the diagnosis is made, then there are several milestones that occur after. One of the first milestones we have after the symptoms start is the milestone of not being able to work outside the home. Now, what will happen is frequently the symptoms of Huntington's will be mild initially, but then they'll progress to a point where people are not able to carry out their normal job. Now, if that job is operating heavy machinery, you may find that that person retires from their work earlier than somebody who had a job that maybe didn't require that kind of skill. So it kind of depends on the patient and what type of work that they're doing, but that is one of the milestones we see. After the patient is unable to work, they then start to have problems with some of their activities of daily living. And that's really when we start to get into the middle stages of Huntington's disease and where I'm going to kind of focus this talk. As the disease progresses beyond the middle stages into the later stages, then the patient's going to be requiring more care, either in the home or in a skilled facility. And then we're going to be thinking about those last stages of disease around the time that they would require palliative care, hospice, or death. Right, so what does this look like? So I took a couple of pictures and charts from the information that the HDSA provides for you, and I'll show you a picture of what that pamphlet looks like. It's available online, so if you want to have a paper copy of some of this, then that would be a really good resource for you. So I'm really going to focus here on stage 2 and stage 3 disease. So stage 2, as I mentioned, the symptoms are starting to become more moderate, and these symptoms can be increasingly worse chorea or balance difficulties, cognitive decline, and behavioral symptoms, some of which I've mentioned. Most of the time in middle stages of disease, the patient will still be at home, but they'll need help. And they'll either be a family member or outside help coming in for some period of time during the day. Now, patients at this point may be transferred into assisted living, meaning that they are somewhat independent, but still requiring help every now and then. Most of the time in middle stage disease, patients are no longer driving. They are needing help with their finances or not doing the finances at all. And they may need some help with some of their daily activities. Disability level is that they're unable to work and they're having mood changes, irritability, or perseveration. So kind of thinking of topics and obsessing about topics over and over again. Late stage disease, we're talking about patients who have really poorly controlled movements, a lot of balance issues, frequent falls. And these folks are going to need really skilled nursing care, either 24-hour care or close to 24-hour care in the home or be in a nursing home. They're fully dependent on others for their daily tasks, and they are, again, unable to work. These patients in late stage disease have dementia, so they have quite a bit of memory problems. They may or may not recognize their family, and they have a reduced ability to communicate. So we're going to talk through these two stages here. So let's talk through the middle stages of Huntington's disease. So really the goal is to improve overall symptoms and maintain quality of life the best that we can by providing resources, medications, or therapies for patients. We really want to keep people safe. And so when you're in the clinic discussing some of these issues with your provider, we're going to be talking about how do we prevent those injuries? How do we prevent people from falling, ending up in the emergency room, breaking bones, those sorts of things. We also want to prevent self-harm. So if there's any signs of suicidality, we're going to be talking about that with you in the clinic. Now, our goal is usually to keep patients in their home as long as possible. It really is frequently in the patient's best for the patient if they can stay in an environment that's familiar with people that they know. But we know with Huntington's disease that frequently is not the case because people require increased level of care than can be given at home, or there may be some paranoia or suspicion of family members that requires people to move into another living environment. So we work with the family and our social workers will work with the family in order to provide the best situation for that person. So let's talk a little bit about the cognitive symptoms in the disorder. Now, memory loss is very common, and this usually will occur in the middle stages and progress through the later stages of the disease. There are some strategies we can use, including medications, to try to slow the memory problem down, but we really don't have a cure, as you know, for the disease. So we will try some strategies, but if people have side effects, we don't have a lot of medications that we can pull for this. Now, strategies can also be used for impulsivity. One of the things that causes patients with Huntington's to be impulsive is this unpredictability. And so what we try to do is make sure that the schedules are predictable from day to day, that the caregiver or the family member in the home tries to maintain a very calm demeanor. So even if the schedule becomes chaotic for some reason, that the caregiver tries to remain as calm as possible, and that will sometimes help decrease the impulsivity of response of the patient. And then, of course, there are medications we can use to help. So irritability, the schedule is really important. Caregivers and family members can try to anticipate when there's going to be a frustrating situation and try to mitigate the patient becoming irritable because of that. So telling people ahead of time what's going to happen, when it's going to happen, reminding them it's going to happen, any change to the schedule, talking about it well in advance, that can help. You want to be able to read your family member. So if your family member with Huntington's disease gives you certain signals that they are encountering distress or that they are going to be impulsive or irritable, you want to be able to read those and modify your behavior. And it can be hard because I think sometimes we are human, and so we kind of react to situations just like your family member or patient does. But you want to try to sit down, be calm, limit your hand gestures to do the exact opposite of what I'm doing, which is using my hands. And then if we have to, we can also use medications for those situations where people are becoming agitated. Now, this lack of insight is something that is really more challenging for the caregivers and for the family members than it is the patient. You want to allow the patient to talk about the disease, but you need to recognize that the goal is not for them to understand their symptoms and to be able to report them accurately. Insight is not the goal for the patient, right? And so because the brain is not able to provide insight, it really is not something that we would expect a Huntington's patient to develop over time. And so I think if the caregiver and family member recognize that, sometimes that helps. It is still a frustrating situation in the clinic, but I think that knowing that it's not a goal can sometimes help a bit. So instead, you're going to want to have goals with the patient that may be focused on certain behaviors. You may want to involve the patient or you with the patient in counseling. And so you can kind of talk through some of that together, again, recognizing that the goal is not to have the patient develop that insight. Now, there are a lot of problems with the front part of the brain, the executive function of the brain in Huntington's disease, especially in the early to middle stages. And this translates into problems being organized. And so you can help this by having the patient or you as the caregiver make a list for the patient and reminders for the patient's prompts, creating a daily schedule that's easy to see, and kind of making it the organization happen for the patient rather than requiring them to do it themselves. Now, as the patient gets into the later stages of disease, their brain will also not be able to process multiple commands at a time. So if you ask them to do 3 things in a row, they may not be able to process that fast enough. And so using one-step comments or short sentences can really help your family member kind of stay organized or do the tasks that you're asking them to do. So a lot of strategies, the neuropsychologists are very good at finding specific strategies if you have a specific situation you're trying to navigate. And so you may want to bring that up in the clinic when you're getting care. Now, some of these other behavioral symptoms can be really a problem for patients and families. The obsessive compulsiveness is an issue. I did mention the urination. This is a very frequent obsession that we deal with in the clinic, where people feel like they need to urinate and they're urinating, 20, 25, 30 times a day, and they're thinking about it over and over again. The same thing with compulsive behaviors, counting, checking, washing hands, although that seems to be a pandemic behavior anyway. Some of this we really can target with medications, and the serotonin medicines work the best for these. And so we use a lot of things like Prozac in the clinic to try to treat these behaviors. Now, some of our patients will have manic symptoms, and that is where they're kind of excitable, elevated mood, a lot of hyperactivity. They're not really sleeping. They're excessively impulsive. This typically needs to be treated. This can't really fix this with goal-directed behavior. So this is something you probably want to bring up and either have your neurologist or psychiatrist address. And then the aggressive behaviors, we see this across our movement disorder clinic and multiple diseases. This really becomes a problem for the caregiver and the family. Patient can't really help it. I mean, it's the disease that's really doing it, and they don't have insight. But we do care about the safety of the family. And so we're frequently trying to develop plans of how we're going to mitigate this. We'll treat the patient so that the caregiver isn't injured. We try to talk through and avoid triggers and do some of those things that we can do to reduce irritability. Now, there are times when we cannot fix this aggressive behavior in the home, and this may be a trigger for us trying to find an alternate living situation for that person, but this is not uncommon in Huntington's disease. And so we just want to make sure that the family and that the caregivers know that it's part of the disease. It's nothing specific to them, because I think there can sometimes be some guilt in the family and caregiver about the aggressive behaviors, and it's really not anyone's fault. This is just the disease, and we just need to make sure that everybody is safe and being cared for. So these hallucinations and delusions, I mentioned them already. The hallucinations are actually seeing or hearing things that aren't there. There can be a whole host of them. We'll have people who see shadows, patients who see other people. There could be animals, all sorts of things. Typically they know they're not real. In fact, it's mixed. Many of patients do not recognize that they're not real. And the delusions are also the same way. Well, they'll have the paranoia, they'll believe that their spouse is cheating on them. And these things, you can imagine, can also be quite difficult to navigate in a home situation. And sometimes this does require us to move people out of the home. All right, so as far as an approach to psychosis, one of the first things we like to do when somebody has an abrupt onset of some of these psychiatric symptoms is we'd like to look at reversible causes. Now, one of the things we will see in our patients, whether they have Parkinson's or Huntington's or any other movement disorder, is they develop infections, especially urinary tract infections. And that is causes an abrupt change in behavior. People will go from not having any of these symptoms at all to all of a sudden hallucinating overnight. And that's really a sign to us that something changed, something new happened. And if that's the case, our patients will call in and we'll frequently ask them to get a workup for infection. So urinary tract infection is at the top of the list. Right now, also COVID is at the top of the list. We've had a lot of Huntington's patients get COVID, and they will acutely worsen even overnight when they're actively infected. Some of our patients will develop pneumonias, they have problems swallowing. And then there are some of these other things that will happen too. People get really dehydrated, they'll have a bowel obstruction, there'll be some problem with the medication, and then all of a sudden they have hallucinations or delusions or some of these other symptoms. Now, one thing that we do try to do in middle stages of disease is reduce medications that aren't needed, get rid of them, because a lot of them will interact. And so when these medications are all on board together, it also can cause some of these psychiatric symptoms. Now, I just want to remind the group, and I'm sure many of you know this, we can treat these symptoms. We do have good medications for depression and anxiety and for the psychotic symptoms. And really, Huntington's disease, like many movement disorders, it's the art of the medicine management. So can we get the person on the right combination to treat their symptoms and improve their quality of life? And unfortunately, we don't have just an algorithm we can use for everybody. Every patient is different and has a unique set of symptoms. And for that reason, we're going to pick and choose which medications we think are going to be right for that particular person at that time. Now, I also like to remind patients we don't want to start a bunch of medicines at the same time. We want to pick one, kind of let it settle in, and then add another for that second symptom. With brain disease, we really have to go slowly, because if you're adding a whole bunch of things at once, you're going to probably have side effects, or you're not going to know which medication it was. So you don't have to know all of these medications, but just to know that for each of these symptoms, we do have options, and you're going to want to talk through those with your neurologist or psychiatrist. All right, so psychiatry. When do we refer to psychiatry? Well, we'll send patients to psychiatrists when the symptoms are not easily treated by the neurologist. Some neurologists do not feel comfortable treating psychiatric symptoms at all, and if that's the case, they'll refer sooner. Now, if patients have psychosis that's not easily treated, that is a good referral to psychiatry, because that's an area in their expertise. This is what they do. They know how to treat and fix psychosis. And so our psychiatrist is very familiar with treating hallucinations and delusions and some of these other symptoms. Aggressive behavior is also something that is very well treated by psychiatry. Now, if patients have a psychiatric diagnosis prior to the onset of Huntington's disease, this makes the patient a little bit more complicated. And for that reason, we may refer to psychiatry a little faster. So say they got a diagnosis of bipolar disorder when they were in their 20s, and then they developed the signs of Huntington's disease in their 40s. We're going to be dealing with someone who's a little bit different than a patient who just developed mood disorders at the start of Huntington's disease. Okay, so those are two different types of patient. And in that case, we really need the expertise of somebody who knows how to treat all of those disorders together. Now, the other time when we'll engage a psychiatrist sooner rather than later if somebody is suicidal. And this is a really important feature that we want to talk about. There are two peaks for suicidality in the disease. And the two peaks occur early, around the time of gene testing, and then in the middle stages of disease. Now, the risk of suicide in general is higher in Huntington's disease than the general population. And it's interesting in that the patient may not tell their family or caregiver that they're suicidal, but if we ask them in the clinic, they will endorse signs of suicidality. And there are frequently these moments in the clinic where the caregiver kind of looks at the patient and says, "What? You never told me that." That's not uncommon. All right, so what will happen is that some patients will have a mood problem, they'll feel sad, they'll feel down, and then they get suicidal. And that's what we would usually see in the general population. But frequently in Huntington's disease, there's no sign that there's decreased mood. All of a sudden, there's just this impulsivity and a suicide attempt. Right, so that can be a little bit disconcerting, especially if this person is in your home, this is your family member. So what we try to do in the clinic, at clinic appointments, is to ask about signs or symptoms of suicidality. If patients have mood disorders, we try to get them treated. And if we're worried, we hospitalize them. So, some of you, if this hasn't happened yet, occasionally we will admit patients right from clinic into the hospital to try to stabilize their mood so that we can get them on the right combination before they go back home. Now, usually we're using serotonin medications in Huntington's disease for suicidality, but it depends on the severity. Now, one of the conversations you may be having with us is about firearms in the home. This is not really a good situation for patients with Huntington's disease, especially in the middle stages of disease, because of the impulsivity. So we will spend a lot of time talking about how to remove the firearms, how to lock them up, how to get rid of bullets, whatever we need to do to try to make that situation safe for the patient. So if you've got firearms in your home and you have someone with Huntington's disease, you really should think through this, because even though there's never been any sign from that person that they would do anything with the firearm, again, the impulsivity is unpredictable. Okay, so we want to keep your family member safe, want to keep you safe. If somebody is suicidal in the clinic, we will get a psychiatric consult immediately. If they're having mood disorders, then we will just have them establish care at a future visit. So very important symptom we need to look out for. So I'm going to introduce you to some of the providers that work in the Huntington's program. And if you haven't encountered them yet in the early stages of disease, the hope is that you will encounter them as you get into the middle stages of Huntington's disease. So social work, of course, is very important. I think Emily would attest to that. And so the social workers, their role is incredibly important in Huntington's, maybe more so than almost any other disease that I see. because of all of the issues that come up that aren't necessarily related to medication or a specific symptom, but about all the host of things that happen in Huntington's disease. And so the social workers can help us with some of these issues. So what are some of these? Well, social workers can help us with counseling, so they can help us with anxiety or depression. They also can help us connect patients to national or local resources. Now, many of you may know the Huntington's Disease Society offers free counseling. You get 8 free sessions through HDSA, which are telemedicine counseling sessions. But I think it's also nice to establish care with someone or counseling with somebody local for either the patient with Huntington's disease or the family member, because I think there's a lot of coping that needs to happen with the family member. It's very hard to be in a family with Huntington's disease, and I think everybody needs to have that support. Now, our social workers also help with the whole host of other activities, such as looking at eligibility or getting people set up for Medicare and Medicaid, setting up services for home health or respite care, support groups, and again, Emily knows all about this, and then helping us with advanced directives and goals of care planning. I want to talk for just a minute about sleep disorders and Huntington's disease. Sleep disorders can be quite problematic. Now, these can start in the early stages, but they will change frequently in the middle and late stages of disease. Now, there are all sorts of reasons why patients with Huntington's will not sleep at night. It could be that they have a movement disorder. It could be that they're not very physically active during the day. They may have psychiatric disorders. So the list is long. We prefer usually to send folks for a sleep study where they go into the sleep lab overnight. We could diagnose the sleep disorder, but in fact, in Huntington's, that's not always possible for obvious reasons. And so we have several strategies that we use other than giving somebody a sedative to try to navigate the sleep disorder. Now, if you have a patient who gets in bed and they start screaming, or there are other things that are happening at night, you may have to use a little bit more sophisticated strategy. Either way, I would bring it up with the neurologist or even the primary care doctor, and they can help you with some of these issues. Now, if people are not getting good sleep, that's going to impact them during the day. It may make them more irritable, it may worsen their mood, it may make them more anxious. So you really want to think about sleep. Ideally, we're all getting between 7 and 9 hours of sleep, or at least we're in bed 7 to 9 hours with maybe at least 6 hours of sleep. And you're all saying to yourself, okay, well, I don't get anywhere near that much. Well, probably none of us are getting enough sleep. But sleep is really important because what happens is that the brain kind of takes out the garbage when you're sleeping. All of the cells are accumulating these proteins and other things at night. And when you sleep, the brain clears all of that out. And you kind of start fresh the next morning. Now, that process is not as good in Huntington's disease, but if you're not getting adequate sleep in Huntington's disease, that process is even worse. So we want to try to do the best that we can to get people some rest, including our caregivers. All right, so let's go back to some of the other professionals that help us. Physical therapy is very important at all stages of the disease, especially as people develop balance problems. And these visits are usually tailored to the patient's needs. So depending on what folks need, whether it's gait training or fall prevention, the physical therapist will work with somebody individually. And there's been a lot of telemedicine rehab going on right now with the pandemic. I think this has been a great option for our later stage patients. Okay, so occupational therapy. So occupational therapy, this comes into play a bit with our adaptive devices. They're a little bit different than physical therapists. So they're really trying to help us with those daily tasks that we need to do. And so you can see this patient here has got a chair in the bath. So this is going to help with bathing. This is the sort of task that an occupational therapist will problem solve with you if you have something that's happening in the home that you need some help with. So what are some of these items? Well, maybe we need help with eating or dressing or hygiene. What if we're worried about driver safety? So many patients in the middle stages of disease are going to stop driving. And this can actually be quite an issue in the clinic. We all know that when you are told you have to stop driving, you lose independence. And so this is really hard for patients. And sometimes it's hard for family members too, because that person is driving and running errands and taking kids places. So sometimes we'll enlist our occupational therapists who do driver safety evaluations to give us the information we need to really help convince the patient and the family that it's time to stop. Now, occasionally, a patient will benefit from some driving rehab and can go back on the road. In Huntington's, when we're referring patients, usually we find that it's just not safe to drive. Now, assistive devices or assistive technology can also be used for several other activities that people are doing. Now, occupational therapists can also come into the home and look at the home environment, do a home safety evaluation, and this can help you in your own specific situation. And I find that sometimes it's hard to know what's happening in the home by the description. So having the therapist in the home looking around and trying to troubleshoot may be the best option for many of our patients. We've started to do some work to see if we can do this via telemedicine, although it's not really standard of care, even during the pandemic, to do home safety eval via telemedicine. So what are some of the devices that we can think about using? So if someone's having problems with handwriting, maybe in the early to middle stages of disease, we can use signature stamps. That's something that used to be real common many years ago, but we bring it back for our patients who need to sign checks or do other things. We will use devices that will take speech and turn it into something that's typed. So Dragon is one company that will do that. So if patients are having a hard time typing on the phone, you can obviously use the voice-driven texting or other applications in order to communicate. Now, if people are having lots of chorea or clumsiness, we may try to use some of these electric products, electric toothbrushes or shavers, so that you don't have to worry about cutting or having problems navigating. Now, I've got an X for the soap. The soap can be quite dangerous in general, and I think it's because people using soap are frequently standing in the shower, and our patients have balance problems, and the soap is slippery. So we just want to think about some of these things that may not be at the top of our mind when we're thinking about safety. We can replace the soap with something that might be a little bit safer, or have the patient sit down and have help. So what are some other devices? So, some of the problems we see are problems getting in and out of bed, turning over in bed, getting in and out of cars. So some of devices can be specifically tailored to the needs of the patient. So for example, putting bars on the bed. Many patients with Huntington's disease in the later stages will have hospital beds with bars on it. If you have a lot of chorea in the bed, then having a hospital bed is a good idea because it will prevent patients from falling out of bed if they wake up at night or as they're falling to sleep. If patients are having a hard time turning over or moving around in bed, you can think about something like a soft pajama, like a satin pajama, and that'll make it easier to move around in the bed. We will frequently use this type of assistant device to get out of a car. So this little thing that you're seeing on the left-hand side of the screen here, it's almost a handle that attaches into the car door that you can use to stabilize yourself as you're getting out. So this can be ordered on the internet. It's not very expensive, but it is really stabilizing for the patient. What are some of the other things we do? Well, as patients are starting to have balance problems, you really don't want them doing activities of daily living and standing. So things like showering, shower chairs, having handheld showers, thinking about bathtubs, even stepping over a bathtub can initiate a fall. And, people falling in the bathroom is really unsafe because there's all sorts of hard surfaces. Frequently, people will hit the edge of the sink. It's kind of a hard edge, and then, they'll get some bleeding in the brain and have all sorts of problems. So we try to make it as safe as possible. What you can see with the toilet is you can see some bars around the toilet. And you may say to yourself, well, how am I going to figure out things that I need? Some of it is looking at when the patient is falling. What are the circumstances in which they fell? If you added a bar in this hallway or next to the toilet, or if you did something in a different way, would that prevent the fall? And the goal is always to get to 0 falls, because if you're not falling, you're not going to break bones. Now, at some point, people will fall enough that you need to get them into a wheelchair. You're not going to want to have them walking anymore. And we're going to get to that when we get to later stages of disease. All right, so let's talk for a moment about our speech therapists. They can be very helpful for us. Many of our patients, especially as we get to later stages of disease, will have problems communicating. This little tool, it's not a very sophisticated tool. It's a talking board. It has on it buttons that are pre-programmed to say certain phrases like I have pain or I need to go to the bathroom. And the patient can just touch it. They don't have to say it, and they don't need a lot of manual dexterity. This type of board can be created by our speech therapist. It's considered an adaptive device or assistive device and can be really useful for our patients. Now, many of our patients will have problems swallowing. We don't want them choking on food or other things because they're going to develop pneumonias. So we ask our patients to see a speech therapist. Sometimes they can do some education. You can thicken up liquids. Liquids are very much a problem with swallowing, even more so sometimes than the solids. So you can cut up the food, you can do certain things like small sipping, but at some point we start to have to modify the diet so people aren't choking and getting pneumonias. And that then eventually some patients will go on to needing some help with their nutrition, such as feeding tubes or other things. So this is really a relationship we start to develop with the speech therapist, and that relationship will change over time as the disease progresses. Now, I just want to comment for a moment about recreational therapies for Huntington's disease. We're really trying to improve quality of life for patients in the middle to later stages of the disease, and you want to be thinking outside the box a little bit. So some of these pictures came from the HDSA book, things like yoga or horticulture therapy. We were doing some horticulture therapy in our Center of Excellence, and the patients just loved it. Music therapy is always a hit. Hippotherapy, if people have good enough balance, they can sit on a horse. That can be also quite popular as well. So I would think about some of these things. It can be very relaxing. It can calm patients down. And I think that it's really nice to include some of these if they're available to you. Now, weight loss is a problem, and I put it at the end of the middle stages because it's also a problem in late stage disease. We want to watch weight because the thinner our patients get, the more likely it is they're going to break their bones if they fall. There's less padding. It's really just a padding issue. And so there's a lot of discussion in Huntington's of whether the weight loss is because patients are moving around a lot. They have a lot of chorea, so they're burning calories. Well, in fact, at the last Huntington's meeting, it appears that the muscle actually metabolizes differently in Huntington's disease than in normal people. And so there's actually muscle atrophy or muscle loss that occurs as part of the disease, not necessarily because you're using more energy. So what do we do about this? Well, there's all sorts of strategies we can use, but pretty much you want to get in more calories. And you do that in any way that you can. So you can have people eat multiple meals a day. I really like the idea of using shakes, really high calorie shakes. You can put 2,400 calories in a shake. You can just kind of throw it in there, and we can get people to drink those even over a period of time. You can schedule eating around activities to make people more likely to kind of be distracted and to do it. You can stock the pantry if people are still able to feed themselves with foods that are easy to open and that are palatable. And then you want to think about high calorie foods. So whole milk products. I love whole milk ice cream around the holidays. Eggnog is all over the place. It has lots of calories. So I'll put some of my patients on eggnog diets. You want to add cream and butters. Some patients will actually have a little bit of blood pressure issues, so we'll actually be adding salt or some other things as well. So if you don't really know exactly what to do and the patients, your family members are not really interested, then we'll actually have a nutritionist help us meet with you and try to figure out what are those tastes that are going to be good for the patient that will allow us to get more calories in. You can use nutritional supplements or drinks in order to get the calories in, but it's really important that we think about this because many patients, especially as they get later in the disease, are at risk for infection, and you really need some extra weight on to be able to manage some infections as well. All right, so let's move into the later stages of Huntington's. And this is a continuum. So it's not like we've tipped over the edge here. A lot of the problems we just talked about are problems that are getting worse. So aspiration pneumonia is very common if people are having problems choking on food. You actually will swallow food into the lungs. And when you do that, that's really not material that should be in the lungs. So you can develop a pneumonia from that. And so we try to prevent that from happening by modifying the diet or prevent people from taking food by mouth and put in a feeding tube. But it is something that, will frequently land our patients in the hospital, and they'll need antibiotics for treatment for that. Tube feedings, I've already mentioned, occur when people start to have problems swallowing. I will say some patients decide they don't want to have a feeding tube. And so usually having a discussion about tube feedings in the middle stages of disease is really helpful to find out what your family member would prefer as the disease progresses. And so that's really a conversation that's best before you get to the point where you actually need it. Now, the impulsiveness is something that I find can be treated, especially if patients jump up quickly and start moving, especially patients who aren't supposed to be up moving without help because they're going to fall. So I use a lot of bed or seat alarms. You just you can order them online, you put them underneath the patient. And so if they stand up, the alarm goes off. There's a number of different types. Some of them will actually be GPS triggered. And so you can get them tagged in through Wi-Fi to your phone. So if you're in another room, person gets up, your phone will alarm and tell you the patient's up and moving. So there's a number of ways you can kind of mitigate the impulsiveness, and you just kind of want to look at the situation. Now, the screaming is really a hard symptom, especially if the person is not able to tell you why they're screaming. Now, you want to try to evaluate the patient for pain. You want to see if the patient has depressive symptoms. But if the screaming continues, you can imagine this can be very hard for family members in the home. So we'll frequently enlist our psychiatrists to help us with the right medication to try to lower the amount of screaming. And it can be done. It can be done with the right medications. Now, use of wheelchair, this as balance gets worse. We put our patients into wheelchairs because we don't want them to get hurt. All right, so this is something that will come up. I've got some pictures and a couple slides to show you some of the things we can look at. Now, I've started a couple things: sexually inappropriate behavior and substance abuse. These don't occur in all Huntington's patients. They're actually in a lower percentage of patients, so they're starred. But you will want to bring these up to your provider, because if we don't know they're happening, we can't help you with it. The sexually inappropriate behavior can be occurring both in the home or outside the home. And sometimes this also requires medication as well. So we definitely want to make sure we address it. If it's bothering you, don't be afraid to bring it up right at the beginning of the visit so we can start to work through it with you. Now, patients with Huntington's disease in the later stages may refuse food. And so it's a good time to have an evaluation of why that's happening. Is the patient not, suicidal, or is the patient refusing food for some other reason? Are they having stomach pain, or is there something else that's driving it? And that can be something that we can get our care providers to help us with, especially if there's home nursing, somebody who knows the patient well, or if we're enlisting palliative care to help as well. So we definitely want to work through this and figure out the why, because it may be something that we can work on. Entanglement or restraints. So sometimes people are at risk of hurting themselves or hurting somebody else, and we'll have to find a way, even for short periods of time, to restrain the patient. This is not an ideal way to treat the patient. We try to do everything but restrain the patient, but sometimes this is what we're left with, especially in the inpatient setting where the environment is a little bit less predictable. So this is something we usually would enlist a psychiatrist to help us with if we're going to make a decision to use restraints. So just want to show some of the resources that we use in the clinic. I think this caregiver guide that's in the middle here in the red for mid to late Huntington's disease is really a good guide for patients and families to use. It's available on the HDSA website. You can download it in a PDF, and it's got a lot of information about each of these topics in there. Now, I've also put on here the 5 wishes packet. This is a packet we use in the clinic in order for people to make plans for their long-term care. So, do people want to have resuscitation? Do people want to have a feeding tube? What do people want for themselves at the end of life? Do they want to be at home when they pass away? Now, this is something that we as physicians think about for ourselves. We will frequently bring it up in the clinic. Many of you, if you come to Rush, will have had this conversation with Krista Cooper, our physician assistant. This is something she talks about a lot in the clinic. And frequently nobody wants to talk about it, especially if you're in the early to middle stages of disease. Actually, I would say it's an uncomfortable conversation at any point during the disease, right? Nobody really wants to think about what the end is going to look like. But it's better to have the conversation before the end arrives. And the reason why is because we want to make sure we respect the wishes of the patient. Sometimes the wishes of the patient aren't the same wishes the family member has. And you have to recognize that you as the family member or caregiver, you're going to have your own feelings about what you want to happen, and it may not be what the patient would want for themselves. So we want to start to have those conversations early. I think that this particular packet, we give it out in the clinic here. We can give out to you. You can start to have those conversations with your family or work through it with you as well. All right, so let me talk for a moment about inpatient and outpatient therapy and inpatient rehab. So when patients need rehabilitation, there are different types of rehabilitation. This happens later in the disease. People will get hospitalized or have a prolonged illness with Huntington's and have to go in the hospital. Now, people are discharged from the hospital based on what the health providers say they need. So if the Huntington's patient has an acute injury and they're believed to recover, they may go to acute rehab, meaning that they can do therapy for at least 3 hours per day. And they're going to get all sorts of therapy. It's going to be intensive, and the goal is to get them home. If they can't cooperate for 3 hours a day, they're going to go to subacute rehab. And subacute rehab is kind of transitional in between an acute rehab and a nursing home. They are going to get therapy, but not as much as acute rehab. Now, we don't usually make the decision. The neurologist doesn't make the decision. The rehab doctor makes the decision based on what the therapists are saying to the patient, saying about the patient. So I usually tell a Huntington's patient, listen, if you work real hard when the therapists come, you can get, they think you can do 3 hours a day, you can go to acute rehab and maybe we can get you home sooner. So we just want to think about this. When people are hospitalized, there are a couple of options afterwards. Outpatient rehab requires a referral from your physician. So depending on what the person needs, insurance will dictate what they can get. So you just want to remember that as you're being seen in the clinic. And then last, there's in-home rehab. And we've been using a lot more of this during the pandemic. This is when the therapist comes to you. Now, this is really for patients who can't go outside the home, they're homebound, right? And so you really are not going to get the level of intensity you would get with therapy in a facility or going to Athletico or some freestanding place. But it is a great option for patients who can't leave the home, and it will work well for patients who are in later stages of Huntington's. Now, I just want to show some pictures of some of the things you're going to want to think about to make your family member or patient more comfortable. And so there are specialized wheelchairs. You know, people have chorea and they're kind of knocking around a bit. You might want to have their own chair made for them. There are wheelchair clinics. We have one at Rush. We just send the patients there and they create something special depending what the needs are. And then you can see for later stage disease, these foam chairs are really nice because especially if the patients are moving around a fair amount, it keeps everything padded, reduces the risk you're going to have an ulcer or skin breakdown because the patient's going to sitting in the same spot all the time. So let's end with just a few slides about late stage disease. And you know, when we think about patients who are seriously ill or in late stages of Huntington's disease, we want to think about a few things. We want to think about treatment of symptoms, especially pain. We want to think about their sense of control. What are the things they can control, and can we provide any sense of control to the patient so they have some ability to make their needs known? Communication is important if at all possible. We want to try to coordinate the care through the disease course and make sure we're communicating even in the middle stages of disease of what the end could potentially look like so that the person can weigh in and make their wishes known. We do not want to prolong dying, right? We don't want the process to be a process of suffering for the patient. And so all of this communication and discussion about what the end will look like is really important. We want to try to relieve the burden on the family and the caregiver. We want to make sure we try to strengthen relationships with loved ones because once the person is gone, then we don't have those relationships anymore. So we want to try to make the needs, all of these needs of the seriously ill person very apparent and addressed when we get to this stage of disease. Now I'm bringing up marijuana now because marijuana comes up multiple times during the course of Huntington's disease. But in fact, in later stages of disease, there probably is a role for marijuana, especially for pain. So marijuana has the best data for pain and for sleep. So if we're needing issues, those issues treated, pure CBD products, not necessarily smoking marijuana because you wouldn't necessarily be doing that at the late stage of disease, but using a compound that's pure CBD can be good for both sleep and for pain. Now, if you're in the early late stages, you need some weight gain as well, you could think about a marijuana product. And you might, something like an edible or a liquid form might be something you would consider. Now, in fact, it's not clear that these products help chorea. There just really isn't good data on that yet. And in fact, they may worsen cognitive decline, but there may be specific instances, especially in late stage of disease, where the Huntington's patient could be more comfortable by using these products. So I would talk about it with your provider. All right, so what do family caregivers want? So we want to think about this in the process of late stage disease as well. And of course, they want to make sure that their family members' wishes are honored. They want to be listened to. They want to be included in the decisions. They want to have support and assistance at home. They don't want to be there alone trying to deal with late stage or end of life. Now, they want practical help. This is where our social workers can come in. They want to make sure that the personal care needs are met. that everybody is being honest about what is going on here. Where are we? Where are we going? How much time do we have? What are we looking at? They want that information. They of course want access to their loved one. So if their loved one is in a hospice facility, they want to be able to be there at the bedside 24/7. And I think that's highly reasonable for a caregiver, especially in those late days of the disease. And then privacy. Privacy is important. It can be hard because you've got nurses and other folks who are involved in care at this point, but it is important for caregivers. So let's talk for a minute about palliative care. Palliative care is incredibly important when we get to the late stage of disease, and this is specialized medical care for people with serious illness. That's the definition. We really want to provide relief from the symptoms and stress of a serious illness and to improve the quality of life of that person, for both patient and for the family. Now, neurologists who treat Huntington's disease are not necessarily specialists in palliative care. There are some, but typically it's a completely separate specialty. So we may have to engage those individuals in late stage of disease to make sure all the needs are being met. So typically a palliative care team involves specially trained doctors. A lot of times they rise up out of internal medicine, so that's really their main home, or geriatrics. And then they train specifically in palliative care or end of life care. There are also nurses and other specialists who work together with the doctor in order to provide this support. Now, there are some places that have palliative care clinics in either neurology or in internal medicine. We actually have a palliative care end stage clinic here at Rush, and Huntington's patients will get referred into that clinic, and that clinic has the palliative care doctor, the neurologist, we have a chaplain, social worker, and a whole host of other people in there. So you want to think about palliative care when you get into the late stages of disease. All right, so let me try to tell you the difference between palliative care and hospice. These are two different things. So palliative care is offered for any stage disease at any age. And you can continue to treat the patient, give them antibiotics for pneumonias, treat them for urinary tract infections, whatever is needed. Hospice is a little bit more specific. Again, it can be at any age, but it's for people who have a life expectancy of 6 months or less. Now, sometimes we will actually refer a patient into hospice. We'll say 6 months or less, but they live 2 years, right? Or they live longer. Or in fact, it turns out they didn't really qualify for hospice at all. That's okay. The doctor thinks, yes, this person could be a hospice candidate, and they go into hospice. It actually gets you a different set of resources than you would get for palliative care. And that's another important difference between the two. So hospice care is when the prognosis is less than 6 months. And there are a number of services that are mandated, especially by Medicare. So you get a team of people to help you, you get equipment in the home, medications, respite care for the caregiver, you get inpatient care if needed, bereavement support. All of these things are included in this hospice care package. So we can start talking about palliative care in the later stages of Huntington's disease, but when we really get to that end, we're now looking at hospice. And the folks who do both palliative care and hospice, they're incredibly wonderful people. They are just the most wonderful providers. They really understand the needs at the end of life. And I think it's important to engage them, not be afraid to bring them in, even if it's too early. They can help really give us some ideas of things to make quality of life better for everyone. So this is the summary. I really want to remind everybody there are all sorts of things that can be beneficial at all stages of disease. And the needs will change as the disease progresses. We want to plan now for the later stages. It is scary. It is really scary to think about those later stages of the disease for your family member. But the more prepared you are now, the more smooth the transition will be as you move into those later stages. And you want to remember that specialists can help at the various stages, and we may need to bring in new specialists even late in the disease.